Hello there. Let's talk peripheral nervous system today. So peripheral nervous system, here we'll see if you follow the note taker, it's the best way to go through. If you're using the book, it jumps around chapters 14, 15, 17, and so forth. So let's talk peripheral nervous system. Now, when we talk peripheral nervous system, you've seen, we've gone through and we've already talked about this division, and we've mentioned this division is going to be made up of everything outside of the central nervous system. And when we say everything outside of the central nervous system, we've looked at what the central nervous system itself is made up of, and the central nervous system itself is made up of the brain and the spinal cord. Excuse me. So everything outside of the brain and the spinal cord now is going to be mainly made up of the nerves. So here when we go through and we talk peripheral nervous system, we're talking all neural structures outside the brain and the spinal cord. That is now the sensory receptors, your peripheral nerves, and also their associated ganglia and their associated ganglia. When we talked about ganglia, we've mentioned the term ganglia. You should all be familiar with the term ganglia now. And also the efferent motor endings. So when we talk receptors, let's talk first sensory receptors, first component here. When we talk sensory receptors we'll see are going to be a cell that's going to be specialized to respond to stimuli. So cells that are going to be responsible or specialized to responding to stimuli. Now, what's a stimuli? A stimuli is going to be a change in the environment. Excuse me, it'll be a change in the environment. That's what a stimuli is. So here now when we go through and we talk sensory receptors, their function now is to get stimulated. Their function is to get stimulated, then in turn trigger nerve impulses. Then in turn trigger nerve impulses along the afferent PNS fibers, which are going to be coursing towards the CNS, Now, when we go through and we talk receptors, I want you to know we have various types of receptors, and these receptors, they are going to be classified a few different ways. First, we'll go through and we'll look at one type of classification, then we'll move to the next, and then we'll move to the third. Now, when we look at the classifications, you'll see classification here of the receptors is going to be done by three basically methods. Now, there's three ways these receptors are classified. So first here, we'll see receptors are going to be classified according to the type of stimulus that they're going to detect. First, we'll see they're going to be classified according to the type of stimulus that they detect. So stimulus type, they're classified by. Second, our receptors are going to be classified by their body location, by their location on the body. By their location. And third, then by their structural complexity. We'll look at the receptor's structure, and we'll talk about that. So let's go through and let's talk first this classification according to the type of stimulus that the receptors will detect. Now, when we go through and we classify our receptors according to the type of stimulus that they will detect, we'll see here they are going to be named according to the activating stimulus. They will be named according to the activating stimulus. So here the first classification of receptors that we'll have are going to be mechanoreceptors. Now, when we talk about mechanoreceptors are receptors that respond to mechanical forces. They respond to mechanical forces. And when we talk mechanical forces, these are going to be forces such as touch, pressure, vibration, and stretch. So those are mechanoreceptors. They respond to those types of stimuli. Then we have thermoreceptors. Now when we talk thermoreceptors, they're going to be sensitive to temperature changes. They are sensitive to temperature changes. So they detect changes in temperature. The name kind of there is giving it away as well. You can see thermo and same thing with mechano now as well. And then photoreceptors, the third type. Photoreceptors. Now photoreceptors, they are receptors such as those found in the retina, such as those found making up the retina. And photoreceptors, you guessed it, they're going to respond to light stimuli. Very good. They respond to light stimuli. Then here, the fourth classification are going to be chemoreceptors. Now, when we talk about chemoreceptors are receptors that are going to detect changes in relation to our basically taste buds and our sense of smell. So when we go through, we talk chemoreceptors, they respond to chemicals in solutions. They respond to chemicals in solutions. So molecules, again, that are smelled or tasted. And also, if we have changes in the blood or interstitial fluid as well, chemoreceptors are going to be responsible for detecting those changes. So respond to chemicals in solutions. And the fifth type then will be the nociceptors. Nociceptors. Now, when we talk nociceptors are going to respond to damaging stimuli that result in pain. They respond to damaging stimuli that result in pain. For example, searing heat, extreme cold, excessive pressure, and even inflammatory chemicals. They're all interpreted as painful. Now, these signals here, they also stimulate. These signals are also going to stimulate subtypes of thermoreceptors, mechanoreceptors, and even chemoreceptors. So, nociceptors. Next, then, you have this classification according to the location in the body. Now, when we go through and we talk about the location the location according to the body, here we're going to see we've got three main classifications here. First, we're going to have exteroceptors. First, we have what we call exteroreceptors. Next, then, we're going to have, after exteroreceptors, we have then our interoreceptors. And then third are proprioreceptors, as we can see here. So extero, intero, and proprio. So we've gone through classes by stimulus. Okay, here now we're looking at location in the body. So here we've got now first exteroreceptors. Now our exteroreceptors are going to be sensitive to stimuli that's arising outside the body. They are sensitive to stimuli that's found arising from the outside of the body. And the name, again, that the prefix there in the name is helping to kind of give that away also, we can see here too. So stimuli arising outside the body or also near or at the body's surface. So outside the body and near or at the body's surface. And this will include your receptors for touch. It'll include your receptors for pressure, pain, and temperature receptors in the skin and most of your special senses. They all get classified here in this category of exteroreceptors. Next, then we have our interoreceptors. Now, when we talk about interoreceptors, we'll see our interoreceptors. They're also known as our visceral receptors, also known as our visceral receptors. Visceral receptors, visceral because we're going to see now when we talk, they respond to stimuli that's going to be arising within the body. They respond to stimuli that's going to be arising within the body, such as from internal viscera, such as from our internal viscera and our blood vessels. So again, the prefix there is helping you out. You got to use that to your advantage. Next, then we have our third classification of receptors according to the location in relation to the location of the body. We have here now proprioreceptors. Now our proprioreceptors, they're going to respond to internal stimuli. They respond to internal stimuli. Now this internal stimuli is going to arise. It'll arise in skeletal muscle, from our tendons, from our joints, from our ligaments, and from the connective tissue that's covering our bone and muscle. And you should know the names of both of those, right? We talk bone, outside, right? Around that prefix we've discussed is very good, peri. Peri now pertaining to bone, then we have periosteum. All right? Connective tissue in relation to muscle. Very good. Very good. Epimysium. 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 Not happy mycelium. Epimysium. E-P-I-M-Y-S-I-U-M. If you remember, we talked about how that epimysium is basically this fascia, and it blends in with other fascia, and it's going to be extending sometimes beyond the muscle to help form the tendon, right? And that's in one type of attachment, and then we had another type of attachment, so it gets all into that. But just from, again, talking about that layer out there. So next then, let's move through and let's talk classification according to the receptor's structure. Let's talk according to receptor structure. So when we talk according to receptor structure, here we're going to see we have a couple of major classifications. Now here first we're going to see we have what we call simple receptors, and then what we're going to refer to then as, you'll see basically our more complex receptors there we'll talk about then next. So first let's talk our simple receptors. Now when we talk simple receptors are going to be modified dendritic endings. They are modified dendritic endings of sensory neurons. So modified dendritic endings of sensory neurons. And they're going to be found throughout the body. They're going to be found throughout the body. And they monitor most types of general sensory information. These simple receptors do. Now, when we talk simple receptors, we'll see these simple receptors themselves now are going to get further subclassified into unencapsulated dendritic endings and encapsulated dendritic endings. So here we can see we've got first our unencapsulated nerve endings, and then we're going to go through the encapsulated nerve endings you can see on the next slide. So going back to the unencapsulated dendritic endings, the first type that we have here are going to be our free nerve endings. Our free nerve endings. Now when we talk about our free nerve endings, we'll see when we talk about our free nerve endings, we're going to see they're present nearly everywhere in the body. They're found present nearly everywhere in the body. They're particularly abundant in epithelia and connective tissue. They are particularly abundant in epithelia and in connective tissue. So here we can see a nice image depicting to us our first type of unencapsulated dendritic ending, which we said is a free nerve endings. So here we can see one image depicting those free nerve endings. Again, they are going to be they're of sensory neurons. They're present nearly everywhere in the body. They're particularly abundant, we said, in epithelia and in connective tissue. Now, we'll see most sensory fibers are unmyelinated. And their distal endings will end, or they're going to have these little knob-like swellings. And their distal endings are going to have these knob-like swellings. So again, those are going to be our free nerve endings. Now, our free nerve endings are going to include warm receptors, cold receptors, and even nociceptors. The second type of unencapsulated dendritic ending you'll be responsible for knowing about are going to be your tactile discs or your Merkel discs. Your tactile discs or your Merkel discs, which we can see right inside of here. Now, when we talk about these tactile discs or Merkel discs, these are free nerve endings that are associated with disc-shaped epidermal cells. So again, these are free nerve endings, so we can see that right inside of here, that are going to be associated with enlarged disc-shaped epidermal cells. And bells should have already been ringing off. We've talked about these before. We talked about these before, and we talked about them before in relation to skin. They're going to be found in a specific layer there as well. We described they're found in the stratum basale, the deepest layer of the epidermis. Now, when we talk about these Merkel discs, they're going to function as light touch receptors and pressure receptors. So they sense light, touch, and pressure. So again, tactile or Merkel discs. So it's a free nerve ending associated with a cell. I've said that before already. Not just now, but in, again, chapters before. Next one, we have our hair follicle receptors. Now, when we talk hair follicle receptors, here we can appreciate our hair follicle receptors. Now, when we talk hair follicle receptors, they are free nerve endings that wrap, again, we've talked about these before as well. They are free nerve endings that wrap basket-like, I've described to you guys before. They wrap basket-like around hair follicles. And I also told you before that they are light touch receptors. They are light touch receptors that are going to be responsible for detecting the bending of hairs. They're responsible for detecting the bending of hairs. Mosquitoes, flies, they come and they sit on the hair, and this is going to basically then activate those receptors and letting us be aware of having something there. So movement in relation to hair. So hair receptors or peritracheal endings, also known as. So next then, we'll move from our unencapsulated nerve endings, right, to then our encapsulated dendritic endings, nerve endings. Now this is that second subclassification that I mentioned here in relation to structural complexity. So here then we can see, now when we talk about our encapsulated dendritic endings, now encapsulated dendritic endings is telling you a lot of information in there, just the term itself. No, the name itself. Now, these encapsulated dendritic endings, they're going to consist of one or more fiber. They're going to consist of one or more fiber terminal of sensory neurons, right? One or more fiber terminal of these sensory neurons that are enclosed, that are going to be enclosed in a connective tissue capsule, that are going to be enclosed in a connective tissue capsule. Now, when we talk about our encapsulated dendritic endings, you'll see most of our encapsulated dendritic endings are types of mechanoreceptors. They're going to be types of mechanoreceptors. And majority of our receptors are going to be simple receptors. They fall under this classification here of simple receptors. Now, when we talk our encapsulated dendritic endings are going to include now, number one, we've got what we refer to as Meissner's corpuscles or tactile corpuscles. So you can see that right inside of here, okay? And here we can see our tactile corpuscles very well. Now we talk about our tactile corpuscles or Meissner's corpuscles. These are small receptors. They're going to be small receptors. Okay, they're oval masses in dermal papillae. They're basically these oval masses in our dermal papillae. So small receptors in which a few spiraling sensory terminals, you can see here, in which a few spiraling sensory terminals are surrounded by Schwann cells. They're surrounded by Schwann cells and then by a thin egg-shaped connective tissue capsule, and then by a thin egg-shaped connective tissue capsule. So again, they're found beneath the epidermis, we said, in the dermal papillae. Numerous found in sensitive and hairless skin regions. Numerous quantities found in sensitive and hairless skin regions, like the nipples, like the fingertips, and the soles of our feet. So again, they're going to serve as light touch receptors and texture perception. So they're involved with light, they're sensing light touch, and texture perception. Next, after Meissner's corpuscles, we're going to have then what we refer to as our Pacinian corpuscles. Our Pacinian corpuscles, or our lamellar corpuscles. Now, when we talk Pacinian corpuscles or lamellar corpuscles, they're known as lamellated corpuscles, basically. Now, here, when we talk lamellar corpuscles, you'll see these lamellar corpuscles are going to be scattered deep in the dermis. They are scattered deep in the dermis. Scattered deep in the dermis and in the subcutaneous tissue that's underlying the skin. And in subcutaneous tissue that is underlying the skin. These lamellar Pacinian corpuscles, you can refer to them as, they are looking onion-like. You can see here they look onion-like, or potato-like, kind of as well, I guess you can say. Same thing as the bulbous corpuscles. So they look onion-like. Now these lamellar corpuscles, they're going to sense deep pressure. Excuse me, they're going to sense deep pressure. Now, they respond only when pressure is first applied. They're going to respond only when pressure is first applied. So there, you'll see also responsible for detecting stretch, our tickle receptors, right, or tickles, and vibrations, So deep pressure, when this pressure is first applied, so they're better for vibrations, and then stretch and tickle as well. These are the largest corpuscular receptors we're going to see. So here, coming back, excuse me, We can see now they're the largest corpuscular receptor. Now, here we're going to see the dendrite is covered or surrounded by a capsule of like 60 layers. It's surrounded by a capsule of like 60 layers of collagen fibers and cells. And you can see how that's quite thick. Next, then we have what we refer to as our Ruffini endings or bulbous corpuscles. Our bulbous corpuscles or Ruffini endings. Now, when we talk Ruffini endings or bulbous corpuscles, they're going to be found located, you'll see, in the dermis, in subcutaneous tissue, in the dermis, in subcutaneous tissue, and our joint capsules. And our joint capsules. They're a bit flat, you'll see in structure. So again, our bulbous corpuscles. So they contain receptor endings enclosed by a flattened capsule. Enclosed by a flattened capsule. So hence the term flat here. And these receptors, they respond to deep and continuous pressure. So they sense pressure, deep and continuous pressure. So more specifically speaking, the stretch of skin, so skin stretch, and also joint movements and joint movement. So our Ruffini endings are our bulbous corpuscles. Next, then we have our end bulbs. Okay, end bulbs are basically Krauss corpuscles. Now they're going to be similar to tactile corpuscles, but not located in mucous membranes. Okay, so here we can see those end bulbs. Next, then we have our muscle spindles, our Golgi tendon organs, and then joint kinesthetic receptors. So here we're going to look at muscle spindles. Muscle spindles, they're going to be basically in relation to fusiform muscle here. We're going to see, and we're going to see now when we go through and we talk. All right, so muscle spindles, let's restart this. So muscle spindles and Golgi tendon organs and joint kinesthetic receptors again. Now when we talk muscle spindles are going to be found, we'll see, in relation to the perimysium. They're going to be found in relation to the perimysium, and what they do is they're going to detect stretch, and they initiate a reflex. They detect stretch and they initiate a reflex. Here you can appreciate those muscle spindles now very nicely. Next, then we have our Golgi tendon organs. Now we talk Golgi tendon organs, they're leaf-like, so the muscle spindles are fusiform-like. Now here, kind of like a fusiform when we talk the shape of muscles and whatnot there as well. Here now we can see, so they're going to be fusiform in shape. Next in here, when we go through, we talk Golgi tendon organs. Now these Golgi tendon organs, what they're going to do is they're going to sense stretch that's caused by muscle activity. So they sense stretch that's going to be caused by muscle activity. And then our joint kinesthetic receptors now will detect stretch then in relation to our joints. So these were again our simple receptors. Next, then here we have what we call our complex receptors. Now, when we talk complex receptors, we'll see our complex receptors. They're going to be receptors for our special senses. They are receptors for our special senses. Now, these complex receptors are going to be receptors that are going to be housed. They are going to be housed They will be housed in complex sense organs. They will be housed in complex sense organs. Now, when we talk about these complex receptors, they are localized collections of cells. They are localized collections of cells that are going to be associated with our special senses. They're going to be associated with our special senses. Now, when we talk special senses are going to include our special sense, basically our sense for vision, hearing, right, equilibrium, smell, and even taste, Now we jump to nerves, and let's talk nerves. Now, when we talk nerves, here we can see a nice depiction of a nerve. We've talked already about nerves, and here we can see now when we go through and we talk nerves, they're cord-like organs. We've got a nice view here as well. They are cord-like organs, and they are a part of our peripheral nervous system, right? We've already established that. And they are going to vary in size. Some are going to be thicker, some will be thinner, some will be longer, some will be shorter. So they will vary in size. And they consist of parallel bundles of peripheral axons, as we've described. And these axons can be myelinated or unmyelinated. Here we can see examples of myelinated axons right inside of here. And then here you can see both myelinated and unmyelinated fibers. So both different types of fibers there. Now, when we go through and we talk nerves, first component I'd like to talk to you about in relation to nerves is going to be the epineurium. The epineurium. Now, when we talk about the epineurium is a tough, fibrous sheath. It's a tough, fibrous sheath that encloses all the fascicles. It encloses all the fascicles. So here you can see a whole bunch of fascicles. Here's one fascicle, here's second fascicle, third fascicle, and here's a fourth fascicle. So it encloses all these fascicles to help form a nerve, to help form a complete nerve. So that's the epineurium. It's a tough, fibrous sheath that encloses all the fascicles to form the actual nerve. Next in here you can see the nerve is made up of a whole bunch of fascicles. So here we can see now we've got 4 different fascicles that are being depicted here. If we move back to this picture, you can see 1, 2, 3, 4, 5, 6, 7, 8 different fascicles. And again, one has been basically removed from that nerve to give you the idea of that one fascicle. Same thing that's basically same thing that's taken place here as well. Now, when we talk this one fascicle, in relation to the fascicles, we have what we call perineurium. Perineurium. Now, perineurium is going to be a coarser connective tissue. It's a slightly coarser of a connective tissue, and it's again a coarser connective tissue wrapping, and it's going to be found binding groups of fibers or binding groups of axons. You can say there as well, into bundles or into fascicles. So when we talk again perineurium, it's going to be found as a coarser connective tissue wrapping that binds groups of fibers or axons, into bundles or into fascicles. So that's perineurium. Next then here we move further in. This is like muscle. Exact same thing as we did with muscle. Now here we move further in, then we can see a whole bunch of axons. Now we'll pull one individual axon out of there. When we talk axons, you can see in relation to the axon, you've got now endoneurium. Endoneurium. Now, when we talk endoneurium is a delicate layer of loose connective tissue. It is a delicate layer of loose connective tissue that encloses the fibers. It's a delicate layer of loose connective tissue that encloses the fibers that are associated. It encloses the fibers, and it's going to enclose, you can see the myelin that's associated with that fiber as well. So it surrounds the axon. Along with the axon, it encloses the myelin in there as well, if that axon is a myelinated axon. So that's how we refer to nerves as being bundles of axons. So you can see that there now. very nicely. Along with that, you've got a couple of blood vessels you can see there, an artery being depicted in red, and then here we have our vein being depicted in blue, and we'll learn more about them as we progress, and you'll see what their functions are in relation to the body, and not just the body, but here in the nerves as well. So let's move then, let's talk about the general classification of our nerves. Now, when we go through and we generally classify our nerves, here we're going to see some of our nerves are going to be classified as being sensory nerves, as being basically afferent nerves, and some will be classified as motor nerves, and then some will be classified as mixed nerves there as well. Now, when we go through and we talk about our afferent fibers, we've seen they're carrying sensory information. This information is going to be making its way towards the CNS. It's going to be making its way from the receptors towards the CNS. Afferent fibers. Efferent fibers are doing the opposite now. They're carrying motor signals from the CNS to your effector organs. When we talk effector organs, we've mentioned effector organs are going to be your muscles and your glands. Now, your somatic fibers, they're going to innervate skin, skeletal muscle, bone, and joints. And then visceral fibers, obviously, you can see blood vessels, glands, and then the viscera. So we have general fibers and we have special fibers there you can see as well. Now here, what this is taking us into now is going to be eventually the cranial nerves. So when we talk sensory nerves, they carry impulses towards the CNS. Efferent fibers are going to be carrying away. And then we talk mixed nerves. We talk mixed nerves, both to CNS and away from CNS. So right, mixed to and from. And like I said, then this is taking us to our cranial nerves. This is taking us to our cranial nerves. Now, when we talk cranial nerves, we can see here we have 12 pairs. Here, we're going to need to know them not only by name, you can see there, also by Roman numeral number, provided that for you there as well, and also by normal Arabic numbers we use 1 through 12. Here we can appreciate all 12 pairs of cranial nerves in this view here. What we'll do is we'll go through each of them one by one and check out each of them individually one by one. Another diagram depicting the same exact thing, going through them here one by one, allowing you to understand which one is where. So you got to use all your resources. Let's start here with then cranial nerve number 1. Cranial nerve number 1. Cranial nerve number 1 is going to be the olfactory nerve, our olfactory nerve. Here you can see, now they have basically they've highlighted optic nerve here. They're trying to show two nerves in one, but we're really focusing on this one here, the olfactory nerve. So here you can see that nerve right inside of here, medial to the optic nerve on both sides. Now when we go through and we talk this olfactory nerve, let's move here to this view. You can actually appreciate that nerve there in greater detail. Now here you can see, now when we go through and we talk, olfactory nerve, you can see the olfactory nerve is going to be found located seated on the cribriform plate. It's found located seated on the cribriform plate of the ethmoid bone, if you recall. And then we had openings, we had holes. You should know the name of those openings there as well, because we've discussed all of this before. This is kind of when all of this online transition occurred. And we've got the olfactory foramina, the cribriform foramina there as well, that are going to allow, you can see now, these filaments to basically penetrate. Now, when we talk about cranial nerve number 1, its function now. Its function is a sensory function. Its function is to carry smell impulses. It carries smell impulses now, and it's going to be carrying these impulses, obviously, towards the central nervous system, as we've discussed. So here we can appreciate the olfactory nerve. The olfactory nerve has got a couple of divisions to it. You can see here first is a tract. That's why I taught you these terms before. And here you can see is the olfactory bulb. What we're going to do is we're going to look inside of this bulb and see why it's widened out here. Next in here we can move over to cranial nerve number 2. Cranial nerve number 2 is the optic nerve. Cranial nerve number 2 is going to have some parts to it. We're going to go through and we're going to check out. First here we have what we call the optic chiasma. and this is the crossover point. And then here we can see the optic tracts, basically, bilaterally. So here when we talk optic nerve, cranial nerve number 2, cranial nerve number 2 is going to arise from the retina. It will arise from the retina, and you can see it's found located on the inferior aspect of that frontal lobe. Running towards, then you can see here the pituitary gland. And anterior to the pituitary gland is where you can see that crossover, the optic chiasma. And then you can see just lateral to it, bilaterally, the optic tract will then continue. Now, cranial nerve number 2. Cranial nerve number 2 is a sensory nerve, and its responsible main function here is going to be to carry vision impulses that I'd like you to know about. It's going to carry vision impulses. And we're going to see in physio. In physio is where you're going to see how it will come into play. You're going to have to actually go through and see that retina in greater detail. We're going to cover that in here. And there you're going to have to actually know what each of these cells are doing in terms of physiology, the electrical events that are taking place, leading to the brain knowing basically what's happening, interpreting these visual stimuli. Using memory and using, basically this information that's been stored there and saying, oh yeah, hi, Mr. John, hi, Miss Jane, and being able to recognize and knowing basically what you have there. You don't walk in saying, who are you, after you've been in same class or the same vicinity with somebody for 16 weeks. Okay, so optic nerve carries vision impulses, sensory nerve. Now you have to know also whether they're sensory or motor, along with knowing the names. Cranial nerve number 3. Cranial nerve number 3. So we can move to then next. Cranial nerve number 3 here, they're depicting to us 3 and 4. Again, some of these pictures they try to do 2. And then here what we'll do is we'll go to just the 1. So here we can see cranial nerve number 3. Cranial nerve number 3 is the oculomotor nerve. It's the oculomotor nerve. It's motor function, location. You can see it's going to make its way from the ventral midbrain. It makes its way from that ventral midbrain all the way over to that orbital cavity to help come in and innervate. We can see extrinsic eye muscles to help come and innervate extrinsic eye muscles. So motor in respect to function. When we say motor, its function is to provide motor innervation to certain eye muscles. Now, which eye muscles? We'll see number 1 is going to be the inferior oblique eye muscle. Number 2, the superior rectus muscle. Number 3, the inferior rectus muscle. And then number 4, the medial rectus muscle. Next then here we've got cranial nerve number 4. Cranial nerve number 4 is going to be the trochlear nerve. So cranial nerve number 3 was the oculomotor nerve. Oculomotor, and now trochlear nerve, cranial nerve number 4. Trochlear nerve, cranial nerve number 4, is going to be found located arising from that ventral midbrain as well, making its way over to the eye, where it's going to provide motor innervation to the superior oblique muscle. It will provide motor innervation to the superior oblique muscle. Next then we have cranial nerve number 5. Cranial nerve number 5. Here's number 5 being depicted along with 5, 6. Here let's check out 5 in its entirety. Cranial nerve number 5 is going to be known as the trigeminal nerve. This nerve does both motor and sensory. This nerve, cranial nerve number 5, is going to be found located at the ventral aspect of the pons. making its way over to, then you can see the face. Making its way over to the face. It runs from this lateral aspect, and it helps innervate then the face. Cranial nerve number 5 is going to have 3 major divisions to it. First division is the ophthalmic division, we can see here. So here is the trigeminal nerve, cranial nerve number 5. And here you can see we've got the ophthalmic division, V1 or 5-1, right? It's being depicted as. And then the second division we can see here is the maxillary division, V2 or 5-2, maxillary division. And then number 3 here, we've got the mandibular division, 5-3 or V3, mandibular division. Now, when we go through and we talk trigeminal nerve is going to be providing major sensory innervation. So it's the major sensory nerve of the face, major sensory nerve of the face, and it provides motor innervation to our chewing muscles. So sensory innervation to the face and motor innervation to our chewing muscles. Cranial nerve number 6 then we have next. Cranial nerve number 6. Now when we talk cranial nerve number 6 is the abducens nerve. Cranial nerve number 6 is going to be providing strictly motor innervation. Makes its way, you can see, from the inferior aspect of the pons, or the superior aspect, you can say, of the medulla oblongata, over to the eye, over to that orbital socket, where it provides motor innervation. And it provides motor innervation, now you can see, to the lateral rectus eye muscle. Cranial nerve number 4, providing innervation. Cranial nerve number 4, we saw providing innervation to the superior oblique. So now here we've got number 6, providing innervation. And it's providing innervation, you can see, to the lateral rectus muscle. So this concludes all 6 extrinsic eye muscles. Cranial nerve number 6, abducens nerve. Let's move then to cranial nerve number 7. Cranial nerve number 7 now, you can see, is going to be known as the facial nerve. It's a very major branch, facial nerve. This facial nerve does both motor and sensory, and this facial nerve has 5 divisions to it. It's got 5 divisions. Here you can appreciate all 5 divisions now. You can see first we have the temporal branch. Okay, here they're depicting it with the hand, giving you all 5, and you can kind of, you can put that right inside of, where am I at? Basically on this side here you can see, okay, or you can see same thing, basically right inside of here. So all 5 branches you've got there. So temporal, zygomatic, and obviously you can kind of think of temporal region, zygomatic bone, zygomatic, buccal, mandibular, and then here you can see you got cervical. So making its way all the way through this nerve by dividing into these 5 branches, and those 5 branches are going to now, you'll see, be responsible for being the chief motor nerve to the muscles of the face, and our facial expression muscles. Sensory, it will provide sensory innervation to the taste buds of the anterior 2/3 of the tongue. It will provide sensory innervation to the taste buds of the anterior 2/3 of the tongue. And that branch, more specifically speaking, is going to be the chorda tympani. The chorda tympani branch you'll be responsible for knowing about. Next then, let's move to cranial nerve number 8. When we talk cranial nerve number 8, you can see now is going to be the vestibulocochlear nerve. So again, 2 nerves being depicted. Let's look at the one, vestibulocochlear nerve. When we talk vestibulocochlear nerve, located, you can see, it's going to be making its way now from also that ventral medulla oblongata, right, inferior to the pons, so all in that area there. And here you can see now It's going to be kind of moving a little bit more lateral now. If we were to go back to this picture here, this original picture, you can relate all of this to here. Okay, so here you can see you've got 6, 7, 8, and then 9, and then 10, and then 11, and then here's going to be 12. So you can see how they're all curving around. So here then when we talk vestibulocochlear nerve, it's got two parts to it. So it's a mixed nerve. It's going to be providing motor and sensory innervation. Motor it provides to the outer hair cells of the cochlea. Excuse me. Motor it's going to provide to the outer hair cells of the cochlea. Sensory innervation, it'll provide sensory innervation to the vestibular apparatus. It provides sensory innervation, you can see here, to the vestibular apparatus. When we talk vestibular apparatus, the vestibular apparatus, we'll see, is going to be made up of the semicircular canals in the vestibule and also provides sensory innervation to that cochlea as well. Cranial nerve number 9. Cranial nerve number 9, glossopharyngeal nerve. When we talk cranial nerve number 9, glossopharyngeal nerve. Glossopharyngeal nerve now, you can see, is going to be also providing both motor and sensory. It also, again, now location, so you got to understand now from that, again, from this medulla oblongata, you can see right inside of there, making its way now to, you can see basically that oral cavity, and along with that, making its way down into the throat area as well. So when we talk glossopharyngeal, tongue, pharynx, right? It's all in that name. So glossopharyngeal is going to provide motor to some muscles of the tongue and the pharynx. So it provides motor innervation to some muscles of the tongue and the pharynx. We can see that there very nicely. And sensory innervation, sensory to the taste buds of the posterior 1/3 of the tongue. So taste to the posterior 1/3 of the tongue and the pharynx. Next then we've got cranial nerve number 10. Cranial nerve number 10 is the vagus nerve. Now when we talk vagus nerve, cranial nerve number 10, vagus nerve, is going to be doing both motor and sensory, and it supplies our visceral organs. It supplies our visceral organs. Cranial nerve number 11. Cranial nerve number 11 is the accessory nerve. The accessory nerve is going to be, you can see, formed by spinal nerves. It's formed by spinal nerves. Those spinal nerves are going to make their way up into that cranial cavity via this foramen we've talked about before, foramen magnum, and then they're going to, you can see, curve around, come together with other fibers, curve around, and exiting that jugular foramen as that accessory nerve, you can see. So that accessory nerve then provides motor innervation to the sternocleidomastoid muscle and also to the trapezius muscle. So motor innervation to the traps and the sternocleidomastoid. Cranial nerve number 12. Cranial nerve number 12 is the hypoglossal nerve. Hypoglossal nerve is a motor nerve. It's going to provide motor to the muscles of the tongue. So it's a tongue motor nerve, basically, you can think of. Provides innervation to the majority of the tongue muscles. Coming back to cranial nerve number 10, it also provides sensory innervation in relation to taste at the most dorsal aspect of basically the throat and the epiglottis area and all the way deep into that pharynx. So taste, you can see 3 different nerves that are going to be involved there. So all cranial nerves, 12 pairs of cranial nerves. Come up with mnemonics. Easiest way to do that is by coming up with mnemonics. A lot of students will use mnemonics for also the motor and sensory, or the mixed component there as well. Next then we have our spinal nerves. Let's talk spinal nerves. Now when we go through, we talk spinal nerves. Here, before we jump in, there's a couple of neurodegenerative diseases we want to mention there as well. Alzheimer's and Parkinson's. Parkinson's we've already gone through, we've talked about, and we've mentioned, so you've got that down there as well. So make sure you go through and understand the rest of this there. And then here we've got Alzheimer's. Alzheimer's, I want you guys to know basically what we're going to have happen here is they're going to have atrophy of the gyri of the cerebral cortex and the hippocampus. So we've talked about the functions of these areas there, and that's why then you'll see memory loss, right? We talked about memory loss, and it'd be found in certain areas, and then also reduced attention span, disorientation. You see there as well in these patients. And now in their actual labs, you can see in scans of the brain neurofibrillary tangles, and then also senile plaques that start to accumulate. So basically a couple of methods of diagnosing Alzheimer's disease, and obviously that's not going to happen until you do an autopsy. So that's unfortunate there. Next in here, you can appreciate basically what you're going to see with Alzheimer's, that atrophy of the gyri, right? We saw how they normally are, nice and plump, you can see there. And here you can see some of those tangles and the plaques. Spinal nerves then. We talk spinal nerves. Spinal nerves, we have 31 pairs of spinal nerves. 31 pairs, 31 pairs. How do you remember this? They're all mixed nerves. How do you remember this? 31 pairs. You're going to have to go through, get all the names down? No. They're going to be numbered. They won't be named, so that'll be a little bit easy. One way to remember, 31 flavors. 31 flavors, Baskin Robbins, right? One of my favorite places to go and eat ice cream. It's one of the original places that have still been there. I think about ice cream. I want to go there now. I don't know if they're essential or not. I think they're essential at a time like this. I'm going to call and find out. So let's get this taken care of. When we talk spinal nerves, 31 pairs, they're going to be named according to their point of issue from the spinal cord. Right? We've talked about the cervical vertebra, so those are going to be our landmarks basically there, and we're going to see these nerves are going to emerge either above or below the vertebra for which they're going to be named. So here when we go through and we talk spinal nerves, 31 pairs, each have thousands of nerve fibers. So each of these nerves are going to have thousands of nerve fibers, and like I said, they're going to arise from the spinal cord, and they're going to supply all parts of the body. They will supply all parts of the body except the head and some areas of the neck, except for the head and some areas of the neck. And like I said before, all are going to be mixed nerves. All are mixed nerves. Now, when we go through and we talk about these nerves are going to be named, again, according to the region they're going to be emerging from. So here when we go through, we'll classify them according to the regions. So first we have cervical nerves. And when we talk cervical nerves, as you can see here, we're going to have 8 pairs of cervical nerves. They're going to be named C1 through C8. C1 through C8. The first seven are going to exit the intervertebral foramina superior to the vertebra for which they are named. But C8 is going to emerge inferior to the 7th vertebra. Next, then we have our thoracic spinal nerves. When we talk thoracic spinal nerves, 12 pairs. They're named T1 through T12. 12 pairs of thoracic nerves, T1 through T12. Next, we have our lumbar nerves. Lumbar nerves, we have 5 pairs. 5 pairs of lumbar nerves. They're named L1 through L5. That's my dog snoring. I don't know if you guys can see Rusty. Rusty boy? Sorry to wake you up. L1 through L5. L1 through L5. Lumbar nerves. Sacral nerves. We have 5 pairs of sacral nerves, and they're going to be named S1 through S5. S1 through S5. And then we have our coccygeal nerve. 1 pair, and the coccygeal nerve is written, or it's known as the nerve C0 or C01. It's a tiny coccygeal nerve. Now let's talk about the general structure. of these nerves and how they're emerging and whatnot. So here, let's go through and let's move over to this picture right inside of here. This picture here depicts the same thing, but without the division of that spinal nerve. So here we can see now we've got these spinal nerves. Now these spinal nerves, we've got first, the nerve is made up from the dorsal root. The dorsal root we've already talked about. We said it's formed from the rootlets. So the rootlets come together to give rise to the root. So here you can appreciate the dorsal roots. The dorsal roots of the spinal nerves are going to contain sensory, I've told you, fibers. They're going to contain sensory fibers or afferent fibers. And these fibers are going to arise from the various sensory neurons. So these fibers arise from the sensory neurons in the dorsal root ganglia. And then they're going to conduct impulses from those peripheral receptors to the spinal cord. Now our ventral roots, they contain, we said in the other chapter as well, the previous chapter, they contain motor or efferent fibers. They'll contain motor or efferent fibers that are going to arise from the ventral horn motor neurons. That will arise from the ventral horn motor neurons. And they're going to extend to, and they will extend to, and they will innervate the skeletal muscles. They'll extend to and innervate skeletal muscles. And then again, you can appreciate all the rootlets. I told you the rootlets will give rise to each of the roots. Then you have the dorsal rami. Now the dorsal rami, here we can appreciate now the spinal nerve penetrates through the intervertebral foramen and you can see it divides. It'll split into two. And here we've got first the dorsal ramus. The dorsal ramus is the branch that's running posterior. It's running towards the dorsal aspect, hence the name dorsal ramus. It's very short. It's a small division. It's a small division of the spinal nerve, and it's found almost immediately after emerging from its foramina. Like the spinal nerves, they're going to carry, like the spinal nerves, they're going to carry motor and sensory fibers. Basically, those rami are going to be, you'll see, all mixed. Next, then we have the ventral rami. Ventral ramus is it's a more larger division running towards the anterior aspect, running more ventral, running more anterior. Next, then we have the rami communicantes. The rami communicantes. And the rami communicantes are going to join the various rami together. They will help join the various rami together. Next is nerve plexuses. Nerve plexuses, now we'll move backwards. We can see here, nerve plexuses, they're going to be complicated interlacings. They are complicated interlacings of the ventral rami. They're complicated interlacings of the ventral rami of the spinal nerves. We'll see except for from T2 down to T12. Okay, so from T2 down to about T12, all the ventral rami do not form those plexuses here. So when we talk plexuses, they're complicated interlacings of the ventral rami of the spinal nerves. Except for T2 to T12, these branches don't go off and form these complicated interlacings, these plexuses you see here. You see that very well. They're not forming these complicated interlacings, these plexuses, as you see, lateral to the vertebral column in certain areas. So all the ventral rami are going to branch, and then they're going to join one another. and they join one another lateral to the vertebral column to form the plexuses, to form these plexuses. So when you talk about the innervation of the innervation of the back is accomplished via the dorsal rami. It'll be accomplished via the dorsal rami. Now, the innervation of the back is going to follow a nice, neat, segmented plan you'll see all the way through. Here we have a nice view that depicts that to you right inside of here. Same thing you're seeing right in there. Same thing you're seeing right inside of there. And right inside of there. You can appreciate it here better. Here are all those dorsal rami, posterior rami. So the innervation of the back innervates in line with, these nerves are going to innervate in line with their point of emergence from that spinal cord. From their point of emergence from the spinal cord. Now, when we talk innervation of the thorax, we can move right back to this picture here. These intercostal nerves, they're formed from the ventral rami of T2 down to T12. Even T1 is contributing a branch there as well. So ventral rami of T1 we'll say to T12. These ventral rami are going to course anteriorly, deep to each rib. In class, I'll usually ask you guys, what's the name of the structure that they pass through in relation to the rib we talked about when we talked ribs. And usually one person will remember. Coastal groove. I usually give like 10 extra credit points because only one person maybe remembers. But you got to remember that there as well, the coastal groove. So you'll see that intercostal nerve, basically a whole bunch of blood vessels are all going to be passing right through that inferior aspect of that rib. So if you don't know where that coastal groove is, I suggest you go back and you look at that coastal groove, because it's going to be an important landmark when it comes to inserting tubes into the chest. You want to go and you want to stay away from that. So to avoid the nerve, the artery, and basically these connective tissue structures that you're going to have there, what we do is we go to and we penetrate in the intercostal region to the superior border of the rib below. So we stay away from that inferior border of the rib above, because that's where you're going to see basically this these structures passing through. So here now, when we go through, again, highly trained individuals, physicians are who are trained to do that type of stuff. And you'll see that when you're rotating through the hospitals. So here when we go through and we talk then intercostal nerves, these intercostal nerves, they're going to branch and they're going to supply the intercostal muscles. They're going to supply the muscles and the skin of the anterior, lateral, thorax, and abdomen. And they will supply the muscle and the skin of the anterior, lateral, thorax, and abdomen. Next one, we have our cervical plexus. So let's go through each of these plexuses now. So first plexus we have is the cervical plexus. Now we talk cervical plexus, I'd like you to know, is going to be found located deep in the neck. It's located deep in the neck, buried under the sternocleidomastoid. Deep in the neck, buried under the sternocleidomastoid, and it's going to be formed by the ventral rami of the first four cervical nerves. It will be formed by the ventral rami of the first four cervical nerves, is what they say there. Now, the single most important nerve for you guys at this level is going to be the phrenic nerve here. The one important nerve making its way from the cervical plexus is going to be, there's obviously way more branches coming off from there. You've seen even some making its way and helping to form this cranial nerve that we talked about. So cervical plexus, deep in the neck, buried under the sternocleidomastoid. And the most important nerve coming from here is the phrenic nerve. Phrenic nerve is going to be a nerve that's going to be responsible for providing innervation to the diaphragm muscle. If you recall, the diaphragm muscle is going to be the biggest muscle of inspiration, the biggest muscle of breathing, right? It separates the abdominal cavity from the thoracic cavity. Talking cavities, my daughter had a little assignment I gave her to do when she read a book on caterpillars and butterflies, and she had to go and do the anatomy, tell me all the anatomy, and go through and draw the butterfly and label all the parts there. So I mean, you got to be doing activities like that for yourself here as well. when you're studying. It's just all, just methods of studying. And that's what I thought of, as an assignment to provide to her. So she had to tell me the thorax, the abdomen, antennae, the head. So she learned those basic parts there. And so she knows the thorax. So then we orientated it to the human body and did head, thorax, abdomen, and then, well, obviously we don't have antennae. So, I told her we have nerves. So I don't know. That's kind of what you've got to do there as well. So here, when we talk phrenic nerve is going to be providing innervation then to the diaphragm. We talk hiccups, right? Overexcitation of that diaphragm because of this phrenic nerve. So you've got that kind of in line there as well. So make sure you've got that understood. Next then is the brachial plexus. The brachial plexus. So we move further down, and here we move further down, and here when we talk brachial plexus now is going to be another plexus here. So it's a very large plexus, the brachial plexus, very important plexus. This brachial plexus is situated partly in the neck and partly in the axilla. Partly in the neck and partly in the axilla. It's going to give rise to all the nerves. It gives rise to all the nerves that supply the upper limb. It gives rise to all the nerves that supply the upper limb. Now, one major branch we're going to have here, so let's move directly to these plexuses, and let's look at these plexuses now in greater detail. So ganglia you got there again. We looked at that picture from the last presentation as well. So here we've got all the different spinal nerves we've been talking about and we've been mentioning. And here you can see the distribution. Very nice pictures. We've seen this picture as well, right? Penetrating into that subarachnoid space. So here's the different plexuses that we've been going through, we've been talking about. Here is the cervical plexus. You can see in greater detail. Here we have that phrenic nerve. Now I want to also mention to you guys, so let's jump back to the cervical plexus. This phrenic nerve is going to be formed from nerve roots C3, C4, and C5. So one way to remember, C3, 4, 5, keep the diaphragm alive. A little cute song. C3, 4, 5, keep the diaphragm alive. And it also helps you to remember not only what is forming the phrenic nerve, but what also the phrenic nerve is going to innervate. So diaphragm. So 3, 4, 5, keep the diaphragm alive. Okay, one way to remember. Again, that's that $150,000 knowledge I described to you guys. So here you can see then cervical plexus, brachial plexus next then. So when we talk brachial plexus is going to be formed from branches, ventral branches C5 to C8 and T1. Okay, and here you can see often in certain individuals when we talk anatomical variability, right? Here you can see even some individuals C4 to T2. C4 down to T2 as well. So more commonly speaking, right, normal is, we don't say normal here because who are we to say somebody with the brachial plexus C4 to T2 is not normal? So when we talk about this distribution more commonly, we talk about C5 to T1. Okay, so here when we go through, we talk then branches from the brachial plexus. Branches from the brachial plexus we're going to see are going to be very important branches. Now, here when we go through, we talk about the brachial plexus. The brachial plexus is such a big plexus here that it's going to get divided up. Parts will get divided up into roots, trunks, divisions, and cords. And then branches. So roots, trunks, division, cords, and then the individual branches. When we go through, we talk each individual nerve branch. So that's what we're going to have there. So roots, trunks, divisions, cords, and branches. So here you can see all of that there very well. Roots, trunks, divisions, cords, and then each individual branch. One way to remember that, I have a mnemonic there as well. Again, $150,000 knowledge I joke with you guys with. Randy Travis drinks cold beers. Randy Travis drinks cold beers. Another one, my cousin, he took the same class at UCLA. He told me one was that he used was really thirsty, drink cold really thirsty, drink cold beers. Really thirsty, drink cold beer. I think that's what his was. I'm not promoting that. I'd say really thirsty, drink cold beverages. Water, right? Best beverage. All right, so here when we go through, then we'll go through each of these different branches now. Let's talk first the axillary nerve. Axillary nerve is going to be a branch off of the posterior cord. It's a branch off of the posterior cord. And the axillary nerve, so it's a branch off of the posterior cord, and it runs posterior to the surgical neck. It runs posterior to the surgical neck. It innervates the deltoid muscle. It innervates the deltoid muscle. I told you guys by the time we're done, you're going to know not only MAOI, muscle origin, insertion, and action, but you're also going to know NAV, MAOI and NAV, nerve, artery, and vein for each of the muscles. I mean, that's the right way to do it if you learn anatomy. I feel that way you've covered everything in relation to each and every one of these muscles. That's what I did when I went to med school after this. It's much easier to get this information down. So here now innervates a deltoid muscle, innervates a teres minor muscle, and it also innervates all right, so here we could see the axillary nerve. So we've talked about the muscles that'll be providing innervation to, and deltoid muscle we said, the teres minor muscle we said, you can see that here very nicely, and also the skin and the joint capsule of the shoulder. This muscle, this nerve, when we look at this nerve, you can see it's a branch, I told you, off the posterior cord. And I want you to know this nerve is going to run, you'll see, posterior to the surgical neck. It will run posterior to the surgical neck. Now, when it runs posterior to the surgical neck, if you recall, we talked about there as well in relation to a very important bone, the humerus bone. And so you can see there now, when that surgical neck we described as being the most common fractured part. So if now that becomes fractured, now not only are we going to be concerned about the fracture, but also we're going to be concerned about this nerve damage there as well. So two components, to say the least, that we have to be worried about there. Next in here, let's move down from the axillary nerve to the musculocutaneous nerve. Now here we can appreciate the musculocutaneous nerve. In yellow, the musculocutaneous nerve is going to be a major end branch of the lateral cord. It is a major end branch of the lateral cord, and you can see it courses inferiorly in the anterior arm. It will course inferiorly in the anterior arm, and it will supply motor fibers of the biceps muscles. It will provide motor innervation, so it'll supply motor fibers of the biceps and the brachialis. Distal to the elbow. Then distal to the elbow, it provides cutaneous sensation to the lateral forearm. I don't know if you can see that here, but cutaneous sensation to the lateral forearm, just right outside of here. Next, then we have the median nerve. When we talk median nerve, the median nerve is going to descend through the arm to the anterior forearm. It will descend through the arm to the anterior forearm. It branches to the skin and the flexor muscles. So it descends through the arm to the anterior forearm, where it branches to the skin and the flexor muscles. It will also innervate the five intrinsic muscles of the palm. It will also innervate the 5 intrinsic muscles of the palm. This median nerve is also responsible for innervating the pronators, the muscles that are involved in pronation, okay, versus supination in pronation. So the pronators. It also innervates the muscles that are going to help flex the wrist and the fingers. Helps to flex the wrist and the fingers. And also the muscles that are going to help oppose the thumb. And it innervates the muscles that oppose the thumb. Now the median nerve, I'd like you to know, is involved in carpal tunnel syndrome. In carpal tunnel syndrome, okay, this nerve is passing right through. You'll see the retiniculum that's basically helping to divide this forearm from the wrist. And as it passes through, it's real superficial. And so you see this nerve gets compressed, leading to then this pain the patients describe in carpal tunnel syndrome. Wrist slashings. In wrist slashings, one method of suicide people will use can also lead to damage of the of the nerves, and this may not be always 100% successful, and so that they end up having then this nerve damage, this median nerve damage. What they're trying to do is they're trying to get their main arteries, the ulnar artery and the radial artery, to basically bleed out. And this nerve is way superficial compared to those arteries. Next, then we have the ulnar nerve. Now, when we talk ulnar nerve, the ulnar nerve, you can see branches off of the medial cord. It branches off of the medial cord, and it descends along the medial aspect of the arm. It descends along the medial aspect of the arm towards the elbow. And at the elbow, it swings behind the medial epicondyle. At the elbow, it will swing behind the medial epicondyle. Then it follows the ulna along that medial forearm. Then it will follow the ulna along ulna, U-L-N-A, along the medial forearm. Funny bone. We described funny bone. You guys went through all the different bones in the body. I don't remember seeing any funny bone anywhere in the body. So when we talk funny bone, what we're actually in reference to, what we're actually referencing there is going to be, you'll see the ulnar nerve. I described the ulnar nerve as passing behind that medial epicondyle. So that's what you have there. What happens here is that we end up stimulating that right in here, and then that is what we refer to as the funny bone. Next, then we have our radial nerve. The radial nerve is the largest branch. The radial nerve is going to be the posterior cord's continuation. It's basically the inferior continuation of the posterior cord. The radial nerve wraps around the radial groove, and then it runs around, it's going to run anteriorly around the lateral epicondyle. So it wraps around the radial groove, runs anteriorly around the lateral epicondyle, and it's going to divide into two branches. And it'll divide then into two branches. Here you can see that. Here very nicely. Okay. And we can see that here very well. So coming down, and you can see it starts to divide. It'll give off then. You can see this branch coming down here, and it'll divide off and then give off basically two branches. Next then we have wrist drops. Wrist drops. Damage to this radial nerve will lead to a wrist drop. Okay. Also, we refer to this as a Saturday night palsy. Okay, or Friday night palsy it became known as. Then now it's like Thursday night palsy. You go to the bar, you have too many drinks, and you knock out basically on the chair there. And when you knock out, right, this chair is too tall, but let's say the chair ended like right here at bar stool. They usually end right here towards the back. And you put your basically axilla right over it and you knock out. And what that does is it pushes up in here, and it pushes up against this radial nerve and causing compression of the radial nerve to occur and leading to then even this wrist drop in patients sometimes as well. Crutches, that's why if you have to use crutches, they'll tell you got to put extra padding on top of the crutches, so when it does push up in the axillary region, it doesn't compress that radial nerve and lead to then any other compression there in relation to the radial nerve. Next, then let's move down. Let's move down to the lumbar plexus. So here's a nice depiction of this brachial plexus there as well. In our cadavers, when we dissect the cadavers, we usually dissect out the brachial plexus as well, and you're able to see this brachial plexus just like this in the cadavers. I mean, it's so beautiful when you get to appreciate these things on the cadavers as well. So same thing there. Okay. Next in here, we can see lumbar plexus. When we talk lumbar plexus, the lumbar plexus arises from spinal nerves L1 through L4. It arises from spinal nerves L1 through L4. It's found lying within the psoas major muscle. It's found located lying within the psoas major muscle. One major nerve we have from here is the femoral nerve. The femoral nerve. The femoral nerve is the largest terminal nerve of this plexus. And the femoral nerve, you can see, is going to provide innervation to the anterior aspect of the thigh. It'll provide innervation to the anterior aspect of the thigh. We also have here the obturator nerve. The obturator nerve, it enters the medial thigh. It enters the medial thigh, I don't know if you recall, via the obturator foramen we saw. The obturator foramen we saw was formed from these various bones. So it makes its way into the medial thigh via the obturator foramen, and it's responsible for innervating the adductor muscles. It'll be responsible for innervating the adductor muscles. Next, then we have the sacral plexus. So we'll move just inferior or caudal to this femoral plexus, lumbar plexus. And here we can appreciate then the sacral plexus. Now, when we talk sacral plexus, it arises from spinal nerves L4 through S4. It arises from spinal nerves L4 through S4. And when we talk sacral plexus lies immediately caudal to the lumbar plexus. It's found lying immediately caudal to our lumbar plexus. Now, major nerve we have here is the sciatic nerve. Sciatic nerve is the largest branch. It's the thickest and longest nerve we're going to see in the body, and it supplies the entire lower limb. It'll supply the entire lower limb except for the anterior medial thigh that we just talked about. This sciatic nerve you can see is formed from the tibial nerve and the common fibular nerve. These two nerves come together, give rise to the sciatic nerve, and the sciatic nerve, then we can appreciate here, it descends in through the posterior aspect of that thigh. You can see there very nicely, and here you can see all these other branches coming off as well, and it makes its way down into that thigh, and you can see here at the posterior aspect of that knee area, right inside of here, you can see we've got that popliteal region. So right in superior to that popliteal triangle we're going to have formed back here, you can see it divides. And then it divides into the common fibular and the tibial nerves. So you can see becomes the sciatic and then divides back to the branches. Now when we talk sciatic nerve, okay, you've got the tibial nerve first. Tibial nerve is going to courses posterior to that knee joint. Courses posterior to that knee joint. You can see here very nicely. Makes its way down into the leg to provide then innervation. You can see in the leg. Now this tibial nerve, you can see its branches making its way towards the front and all helping to provide innervation basically to these deep structures of that anterior aspect of that leg. Because when we talk common fibular nerve, it's also known as the common peroneal. Now when we talk this fibular nerve, you'll see this common peroneal nerve is going to descend from its origin and it wraps around the neck of the fibula. You can see that there very nicely. It's common fibular. Okay, tibial we said is going to descend through. Common fibular is going to wrap around the neck of the fibula. That's an important landmark. So it wraps around the neck of the fibula and it's going to divide. It will divide then into a superficial and a deep branch. It divides into superficial and deep branches. And then here you can see the deep fibular making its way down, and then the superficial will remain basically superficial. Next in here we can appreciate various other images depicting to us again the same exact thing. But then also here we have our motor ending. We have a neuromuscular junction. This neuromuscular junction, just like the name says, neuromuscular, we have a nerve and we have a muscle. You've got this in lab you're supposed to be looking at as well. You're following along with the labs. So this is the second part of lab. We did the first part in the last class, so here we have the second part. So you're looking at these different slides there as well. You want to be adding in a couple of slides every day as well. This way you get all 6 slides taken care of there also. So neuromuscular junction, this is where the terminals of the somatic motor fibers innervate voluntary muscles with effector cells. Innervate voluntary muscles with effector cells. So here you've got the neuro component Here's the muscular component. We've already gone through, we've talked about this, you've seen this. Here's acetylcholine found within those vesicles. The acetylcholine is a neurotransmitter that's going to be removed via exocytosis from this terminal and the terminal bouton and into the synaptic cleft. From the synaptic cleft, the space you have in between the two cells, the synaptic cleft, it'll diffuse through and it'll bind to receptors on that basically on that muscle's sarcolemma. So when it binds to the receptors on the muscle sarcolemma, it's going to help trigger then action potentials or nerve impulses along this muscle, allowing those impulses then to travel all the way down the sarcolemma. Then that's what we've got there. And then you can go through and look at the innervation of cardiac muscle, smooth muscle, and glands. You'll see that's autonomic innervation. That's going to be much simpler than the junctions that are formed between somatic fibers and our skeletal muscle fibers.